My name is Charles Sentiel. I'm an associate professor in the Rutgers School of Communication and Information in the Department of Library and Information Science. And I am an information scientist by PhD training. I'll also add that I have an MBA and I also have a master's in social work, and I'm a licensed clinical social worker in addition to a researcher. So I do actually interact with patients and treat patients in my therapy practice. What I'm going to do today in my lecture is to go through a couple of projects, recent projects, current projects, and projects that I have on the horizon that all coalesce around health equity, which is my area of focus. And this center, Transforming Lives in Africa Through Research, is a wonderful synergy for what I do, because my research and the teams that I'm a part of are all about trying to influence lives and improve well-being through research. So there's synergies there. An overview of my talk this morning, and by the way, thank you again for hosting me. I mentioned that previously, but I want to make sure that the people online hear that too, and the folks in the room. I really appreciate it. I've been here in Kenya, my first trip to Kenya. I've been here since Wednesday, and this is sort of the culmination of my visit. I was in a few meetings last week, and I'll talk about that project in a moment. And here I am with the opportunity to meet and speak with you all. So an overview of the talk. I'm going to talk about some of the projects that I am involved with, and I'll talk about them individually. Then at the end, I'll bring it together, or attempt to, by talking about how important it is to engage with communities, individually and collectively, in order to tell effective stories. And storytelling is something that has become really important to me as I attempt to disseminate my work. And it's important for we scientists to not assume that we're only talking to each other, because if our work is going to have impact, it must be accessible to the vast majority of the population who don't speak and think like scientists like we do. I want to state, as I was preparing for this talk, that influencing health policy or policy in general is difficult. As I mentioned, I've been here for almost a week, and I was in meetings at the Fairmont, actually, with other researchers from around the world, and I was talking with some of them about this talk that I'm giving this morning, and how I was going to talk about policy and how to influence policy. So I was speaking with one researcher who focuses on policy, and I asked her about, well, how do you use research to influence policy? And she said, that's really hard. It's difficult to do that. So I want to make sure that I emphasize how difficult it is to translate research into policy, but it's an effort that we make. One of the points that I want to make, though, is that policymakers or individuals or groups are not solely influenced by numbers, empirical data, or return on investment. That's a part of the story, but it is not the complete story. I'd like to talk initially, briefly, about health equity and how it's a persistent human rights issue. And I ground my talks, many of them, in this concept because I haven't seen evidence that achieving health equity is always a universal goal. I want to share a quote, a part of a speech. We are concerned about the constant use of federal funds to support the most notorious expression of segregation. Of all the forms of inequality, injustice in healthcare is the most shocking and most inhuman because it often results in physical death. The rest of it. I see no alternative to direct action and creative nonviolence to raise the conscience of the nation. This was Martin Luther King Jr. In 1966, it happened to be at an annual meeting of the Medical Committee for Human Rights in Chicago. And I say that because health equity is not, or the visibility of health inequity, I should say, is not a new phenomenon. However, we're still miles away from achieving it. And it's not necessarily a health issue. It's a human issue. It's a human rights issue. And I want to make sure that when I give my talks, I ground them in that fundamental premise. For the specific agenda. So as I've mentioned, I'll go through some of the projects that I'm involved with, the teams that I'm a part of. In the middle part, I'll give a look to the future and some work that's on the horizon. And then I'll attempt to summarize the talk by emphasizing that engagement and storytelling, as I've mentioned, is paramount, is really important. And that the work requires replenishment, is the word I use even in my therapy. Replenishment, it means it takes stamina to continue and to persist in this work, because some of it can be quite discouraging at times. Recent health equity work. So this is the project that actually brought me to Kenya. The Mercury Project is a project that was funded by the SSRC, or Social Science Research Council, which some of you may be familiar with, given that this institute was started with Rockefeller Foundation funding. The Social Science Research Council is also a council of foundations of which Rockefeller is a big part of it. And a couple of years ago, they released this program to combat misinformation globally called the Mercury Project. And I and a colleague of mine, a very dear colleague of mine, Dave Rand at MIT, decided that we should go for this grant. At the time, I was finishing up a visiting associate professor position at MIT. And that's how Dave and I met initially. So we wrote a grant, as many of you know, and we were fortunate enough to be awarded one of the grants. And this project is the project that brought me to Kenya, because last week we were basically reporting out what we found as a result of 2 years of work on this project. Misinformation is something that is very well known now throughout the world, because we find it not just in health, but we find it in politics, we find it in all kinds of different arenas. And it's something that is around the world. So misinformation is not just a continent specific, but is actually a global issue. And as I was getting into this work, as an information scientist, obviously interested in misinformation, as a health equity researcher, very interested in misinformation as discussions of vaccines started to emerge and what good or bad could come from them. And as I was embarking upon this project, I was thinking globally about this wave of misinformation. But it happened and is happening in a larger context, I would argue, of mistrust in institutions. So around the world, in Latin and South America, that's where we did a lot of our work, that groups around the world remain without a COVID vaccine, or at least they're not vaccinated. And misinformation, as most of us know now, about the safety and efficacy of the vaccinations and a general mistrust of institutions are at the root of that. It's important to be longitudinal in this kind of work and not think of COVID as just a phenomenon that may have began in 2020. The trend in national governments experiencing a decline in trust has been steady for the past 6 decades. That top line is Africa, I know that's difficult to see here. I can't point to it. Let me walk over here. This line is Europe. This line is Latin America. And we see that trust in institutions has gone down. The x-axis is 2000 up until 2020. So this is part of a longer trend. Now, what are the implications of low trust for institutions? That was something that became a question that I wanted to know just for the sake of my own translation of this work. The message is low trust is associated with poor health outcomes and financial outcomes. COVID-19 was much like other health crises. High public trust is a crucial determinant for the successful responses to them, as defined by low mortality. So a successful response to the Ebola would be low mortality. I think that's a fairly straightforward metric, way to measure it. And what we found around the world is that trust in national institutions is associated with lower mortality. And that makes sense, I think, as institutions are tasked with providing information about what's going on, what's causing it, providing information about treatment. So the message here is that high public trust is associated with certain, that's the left column on the table, with certain phenomena we find across societies, across the world. So high public trust is associated with improved compliance with regulations, tax collection, respect for property rights. I found that one particularly interesting as I was looking at this. Also, high public trust associated with improved investor and consumer confidence, vital to job creation. There are financial implications to high public trust. And also sustainable development goals, or SDGs, like eliminating poverty, contributing to the effects of climate change, and building peaceful and inclusive societies. Not docile societies, but societies that are inclusive and facilitate healthy debate. Conversely, low public trust is associated with support for extreme political views. So when there's mistrust in societies, again around the world, high mistrust, extreme political views. Also, increased public discontent and violent conflict versus nonviolent protests. And I think intuitively that makes some sense, doesn't it? That when a society, when a collective does not trust institutions, then you get unrest, violent unrest often. And that happens all over the world. So it's important for those of us who are concerned with misinformation to understand what the implications of mistrust are, because misinformation tends to flourish in environments where there's high mistrust. The bottom line here is that nations are healthier when citizens and businesses and financial institutions trust public institutions. Now, that doesn't mean public institutions are trustworthy. What it means is that there are implications to having a society with high mistrust. Implications health-wise and implications financially. And as I mentioned in the introduction, I have an MBA. I'm an entrepreneur at heart. And I think about, in the context of health, benefits in terms of human benefits, saving lives, as well as financial benefits, costs, because both are important, particularly in influencing policy. Now to the project specifically. These were our research questions, again, the Mercury Project, to figure out how to combat misinformation. And there were several projects around this topic. This just happens to be the one that we worked on. Around the theme of engagement, what we were interested in is how can we involve members of a community in the generation and revising of public health messages. Our simple premise was, how can we compare the institution's messaging around public health with what people say would be effective about messaging around public health? It's a fairly simple premise. Our hope was that there would be an improvement on public health messaging, and we actually found that. I'll get to that in a moment. So, involving members of a community. This is all online, by the way, so this work was all done online. Involving members of a community in the evaluation, the selection and evaluation of public health messages. For example, what do they think? What do communities think would be convincing or appropriate in terms of public health messaging? And does identifying more effective messaging in the context of online surveys translate to greater messaging impact? What impact public health messaging has, as measured by social field experiments using social media. And then beyond the methodological innovation, that's a fairly innovative approach that we took. And of course, as scientists, we don't always know what's going to happen. But our hope is that this innovation will result in a better, more improved way of generating and disseminating public health messaging by involving community members directly into the process of creating those messages. Our sampling are in three regions: in Brazil, in Mexico, and in the United States. And we picked groups that were either partially or entirely unvaccinated. Again, this project started in September of 2022, September of 2022. So this is about 2 years ago. So in Mexico and Brazil, we targeted groups that were partially or entirely unvaccinated. In Brazil, we found that these groups are strongly religious. So we had conversations with our community partners around identifying additional sub-communities that we would be able to reach. Now in the United States, we're sampling Black or African American and Republican voters. These are communities that tend to have higher mistrust, which translates into vaccination rates. Outcomes, what were we looking for? Simply self-reported perceptions, beliefs about safety of vaccines, for example. And we used COVID and HPV in our experiments. And intentions, do you intend to get vaccinated? Our hope is to have behavior ultimately, but it can be difficult, as many of you know, to get at that information when you're doing online experiments. But we can certainly and have measured attitudes, perceptions, and beliefs. Self-reported, obviously. Intentions and trust in institutions were part of what we did. We used an iterative process of involving members of specific sub-communities. We used Facebook, partnered with them, and public institutions, NGOs basically, in Mexico and in Brazil, who were involved with vaccination. And our main goal, as I mentioned, was to evaluate the effectiveness of community-driven messages. What were the messages? Well, we asked individuals from these communities to come up with messages. What do they think would be particularly impactful? These are just text, just people typing in responses, using the platform of these targeted institutions. We don't know who these people are. We're simply running these experiments on Facebook using their platforms, the NGOs. We were interested in if involving, as I mentioned, involving communities who may be disproportionately impacted by mistrust or characterized by high mistrust, and therefore low vaccination rates based on perceptions. We're interested in if those communities could offer a more effective way to come up with public health messaging? Would they be perceived as more trustworthy if the communities of interest actually came up with the messages? One of the institutions that we partnered with in Brazil is the name here. My Portuguese is very bad. And I put our picture up here because Flavia, that's Flavia on the left. That's Luke in the middle, that's me on the right. I had never met Flavia in person, and I'd only met Luke a couple of times. So we had a chance to come together. This picture was taken, I guess, on Thursday at the University of Nairobi, where most of our meetings occurred, at the Fairmont and the University of Nairobi. So I wanted to make sure that I gave them a shout out as well, because that organization was critical to providing the platform to run our experiments. And this is an organization that's been around for many years in Brazil that is focused on vaccinations. In the first study, I'll go through this relatively quickly in the interest of time, and I see some of you taking pictures of the slides. I will leave these slides with you so you'll have access to them. So in the first study, so we ran several studies. In the first study, we wanted to crowdsource messages. What that means is have the survey participants come up with their own messages, and then get predictions for how effective they might be. And then compare those messages to the public health messages to see if they were more effective. Study 2 is to have the crowd, again, the research participants, who we never met, didn't know who they were, determine which messages would be more effective. And then compare, using randomized controlled trials, the difference between the messages. What we found is that the messages that were predicted by the community to be more effective were significantly more impactful than those predicted to be less effective. The point is that the crowd was correct. The crowd understood, and by crowd I mean the wisdom of the crowds, the people who were most affected by these issues were able to determine which messages, this is in both Brazil and Mexico, were more effective. So what we're seeing here is that the messaging that was generated by the crowd and then selected by the crowd were more effective than public health messages. And this was a theme that we saw throughout our work, and that's the headline. Another study, again in the context of this similar methodology, Brazil and Mexico again, is that the crowdsourced selected messages had the highest effect on vaccine attitudes, meaning more positive attitude about vaccines. And what was, I don't want to use the word remarkable here, but what we were enthused by as a research team is that we saw those effects in Brazil and Mexico similarly. So then, in our third study, we asked the community to select the top messages around HPV. And our partners helped create ads, very quick, like think TikTok ads, around what the crowd indicated would be effective. And we put those ads, again, with Facebook as a partner, that Facebook users would see these ads. I want to show, let's just show this slide. So this is part of what we, Luke, and I and Flavia presented last week, is that for COVID and HPV vaccines, we find that the most effective ads, messaging, that influences perceptions of HPV and COVID vaccines are the ones that the crowd created and then identified. So we're effectively crowdsourcing public health campaigns and showing empirically that it's more influential than standard public health messaging, which is what we didn't know when we first started if that would turn out to be the case, and it turns out to be true in very large online experiments. This is the larger team. I just want to make sure we give a shout out. We had, as you might imagine, running these online experiments using Facebook platforms of NGOs took a lot of coordination, and it didn't start right away smoothly, but we came together and were able to generate some pretty interesting data, which we hope, when we disseminate it, we hope that public health messaging will consider this as not a replacement necessarily, but an alternative to determining what public health messaging might be effective across conditions, across messaging, whether it's COVID vaccination, HPV vaccination, or other pressing public health issues. The method is what we were after. How effective can this method be? And what we found is that it's fairly effective. All right, next project. Generative AI, which is getting a lot of press now. And in my classes, I teach a health informatics class, undergrad to undergraduates. And I try to ground our understanding of certain terms that we hear. They're ubiquitous, but what are they? So generative AI creates new content using models trained on existing data. And that part is highlighted for a very specific reason. Using models trained on existing data, existing text. And these models, trained on existing data, will continue to permeate every business sector, including healthcare. So, as a health equity researcher, it's important for me to understand where there may be latent, hidden inequities that may emerge from this wonderful intervention, or innovation, I should say. Researchers like me and others support responsible AI, and that's something that has gotten some attention, at least in the circles that I run in. Good. Responsible generative AI needs to occur by working collaboratively with other sectors, like financial, other sectors outside of healthcare, to identify where there may be inequities and understand what the implications of those inequities are. Much like I shared with my previous project, it's not just about the existence of mistrust, but what are the implications of it. So it's not just about inequities that may emerge in generative AI, but what are the implications? So with that spirit, I decided to start a project to examine the language, stigmatizing language in nursing notes. Clinicians' notes contain stigmatizing language, and I'll get to what that is in a moment. And that's been well researched for many years now. There are 3 forms of stigmatizing language that's found in clinical records. Labeling the patient as the other, diminishing their individual identity, like substance abuser, like drug seeking, in the medical record. That's one. Second form of stigmatizing language found in the medical record, and this is US-based research, US English-based research. Assigning blame, which connotes disbelief, mistrust, or an inflated intentionality, or a decision that a patient might be making, that they're non-compliant with their medications, or that they're poorly controlled. Those are examples of stigmatizing language. And the third form is invoking peril or danger, which implies intentional efforts to endanger staff, like patient is belligerent or combative. So these are examples of stigmatizing language in English in the US, large data sets. So these papers that this insight comes from are from very large data sets, large hospital systems. And what we found, or what they found, because I didn't do this work, is that stigmatizing language is found in clinical records, and it tends to be grouped in these three categories. Now, natural language processing, which again, when I teach undergraduates about what that is, or NLP, a lot of discussion about that in terms of ChatGPT and its influence. All NLP really is qualitative analysis at a large scale. Qualitative data, words, and audio, and images, but in our context, words. Quantitative data, numbers. That's it. And NLP is a wonderful tool, natural language processing, to do qualitative, again, qualitative analysis, words, on a large scale, for all kinds of different purposes. But for what I was interested in was looking at how stigmatizing language may appear disproportionately in some patients' records. This research, again, the research that I didn't do, found that stigmatizing language actually results in disparate care. Should I use this one? That patients who have stigmatizing language in their medical records tend to get, they're less likely recommended for treatment and connote negative attitudes about those patients that indicate, or that result in different care decisions, like timing of and level of pain medication. So stigmatizing language in the record actually has implications in terms of the type of care that a patient gets. And these are just examples, again, in the US context of what stigmatizing language is versus non-stigmatizing language. So, for example, substance abuser versus substance use disorder or substance misuse. Stigmatizing language, non-compliant, poorly controlled, versus barriers to getting medications or barriers to following dietary recommendations. Or stating disease has progressed, disease progression versus poorly controlled. And then the last category, stigmatizing language, belligerent. Patient is belligerent, aggressive, hostile, combative, these kinds of words, versus agitated or distressed, or may lack familial support. So these words can describe the same phenomena, but they describe it differently, don't they? You get that sense, like there's a different tone to the left column versus the right column. Also, and this is an area actually that I'm looking at with mental health as well, looking at notes. So, in the United States, 60% of patients who are offered access to their medical records, these notes, these words, potentially reading them, view them at least once. So patients are able to access these records and see what words are used to describe them. And in a mental health context, that also has unique implications because we therapists take notes on our patients, and we must consider that those notes could be read by a patient. That's another project, though. So what did I do with this? Well, I found, as a racial equity researcher, again, situated in the United States, but with a global perspective, looking to expand. But for the sake of this discussion, or this project, I was intrigued by where there may be racial inequities. And as you might imagine, there were and are some. So black patients are more likely to contain stigmatizing language. And there are models, and this is some of the work that I was a part of, there are models that can just look at the language in the record. These are just nursing notes, and I'll tell why we're using nursing notes in a second. But we can build models to predict reliably the race of the patient just based on the notes. Because stigmatizing language tends to show up more in minority patients. And as I've mentioned, that has real implications on care. So some of the specifics. Black patients have 2.5 times the odds of having at least one stigmatizing descriptor in the history or physical notes compared to white patients. And this particular study, 40,000 patients, big studies. And then models can determine, as I mentioned, the race of the patient based on just the language used in the notes. So as we discover health inequities and the drivers of them, one of many, is the use of stigmatizing language in nursing notes. Now, as I mentioned, why nursing notes? Well, nurses, again in the US, tend to take notes contemporaneously, real time. This is on a typical hospital floor. They'll go see a patient in room 7, they'll come back to the nurse's station and capture the notes. So we know when they took the notes, how often they took notes, and then what they said, what did they observe about what they saw. Versus physicians tend to take notes in a batch form. And I did my undergrad in math and computer science, so I think about coding, batch. So batch processing, meaning physicians tend to do tend to enter many different patients' notes at once, not contemporaneously, not when they're actually making the observations, whereas nurses make observations contemporaneously. So what to do with this? Well, during this time, and this was right around 2021 or so, I had a wonderful friend, colleague in Brazil who was a nurse, and I thought, here's an opportunity to collaborate. We've already found in the US that there are racial disparities associated with stigmatizing language in nursing notes. I wondered if we also would find racial disparities and stigmatizing language in notes in Brazil. So, as scientists, we don't know a lot of times, and we just want to find out. So we did it. So I wrote a relatively small grant, got some funding, and launched another project. Now, part of the goal was to identify inequities that have real implications on care delivery. But a larger goal here in the context of large language models is to introduce, if I may use that term here, introduce analyzing for racial inequities in the language that we use in notes. So, I went to Brazil a few times to kind of get going with this. And we have data on, it's all in Portuguese, as you might imagine. We're not translating the notes into English and then looking for stigmatizing language. We're actually keeping them in Portuguese and working with our colleagues to identify what stigmatizing language in Portuguese might look like. We know that this is stigmatizing language in English, but cultural contexts are important, as we all know. So we're developing lists of what stigmatizing language is in Portuguese so that we can continue our analysis of the nursing notes, which are in Portuguese. Still early. It took some time to just get to the point of collecting that data, but that's part of the fun. And we're running models now to identify where we see racial differences, or difference according to race in terms of stigmatizing language. So this is I guess I call this current project, still analyzing data. This is our team. We have a team in Brazil, as you might imagine, and we have those of us based in the US, working pretty closely together to do this, what I think is interesting work. All right, next project. Developing a health information app for the Latinx community. This one is situated in New Jersey. So before the pandemic, I wanted to do some work with the Latinx population in central New Jersey, where I live, and where Rutgers has several campuses across the state, but the campus that I am on is in central New Jersey. And there's a high Latinx population from different parts of Latin America. And I have a collaborator there who I'd gotten to know over a few years. I got to Rutgers in 2016, by the way. And I wanted to do some work with her. So before the pandemic, we decided to launch a project to understand what the health information needs are of the Latinx community in central New Jersey. Kind of a classic information science, health informatics project. The title, Understanding the Health Information Needs of the Latinx Community. Again, pre-pandemic. That's important to understand the timing here. Launched it, started collecting data in the fall of 2019. Now, the pandemic disrupted a lot of things, including this project, where I was going around central New Jersey having focus groups with Latinx folks, asking them what their information needs were. We also conducted focus groups over Zoom. As the pandemic shut down the world, basically, in terms of in-person interactions, March, April 2020. So we did some focus groups, we continued the work, and then the pandemic really had an effect on this community, and we had to scale back our work quite a bit. But we picked it up again in September of 2022, and we resumed focus groups in person. And at that point, I and my collaborator understood that what these individuals needed and wanted was a smartphone app that was for them, that they trusted, that they could get health information from, like where to get vaccinations for their children and themselves. Because what they were telling us is that when we got information about where vaccines might be available, like at their children's school, that they were available for the children, but not the parents. So these disconnects were being experienced and described by these folks, and they wanted an app. I asked some of them, why an app? App's easy, we carry smartphones, and as long as that information is trustworthy, well, what makes it trustworthy? They said, if it came from us, we'll trust it. And it wasn't that, and these are just, our findings are still being analyzed, so I'm giving you a little bit of a preview here. It's not that they mistrusted, say, the county health department or the state health department. It's just that the websites were way too confusing for them to get to. And when I tried to access my county website with them, I could see their point. I'm an information scientist, and it wasn't straightforward for me to figure out and navigate some of these sites. So we're in the process of building prototyping a smartphone app. This is our team. So that's Teresa. She's wonderful. She's been working in this community for 20 plus years. And we have several students that are also working with us. Students at different levels, PhD students, undergraduate students, who are helping translate some of the focus group data and then analyze it to understand what the community said they wanted and needed, and then to actually prototype the app. Also, I want to add that during the time that I was at MIT, and it was virtual, this was during 2020, 2021, I got to know some individuals at the Boston Public Health Commission. And I told them a bit about this idea at the time, of this project as it was evolving, as the pandemic was raging. And they too were interested in getting information to different communities And once we have our prototype based on the New Jersey focus group data, we'll connect with them to figure out how we can develop synergies with what they're doing in Boston. Engagement, again, another theme here. All right, another project. This one is on the horizon, but right before us. Public health dashboards. So public health dashboards simply provide public health information to facilitate the monitoring and prediction of disease outbreaks by continually monitoring the health status of the community. So those of you who are interested in and work in or are epidemiologists, familiar with the concept. They might be called different things, but dashboards is the word that we use, at least in our space. And this involves health communication professionals, as well as, or researchers, I should say, as well as information scientists like me. So the title, we have our titles for our projects. Advancing Theory, Research, and Practice in Designing Public Health Data Dashboards to Better Communicate Complex Information to a Diverse Audience. It's a lot of words to say. We're trying to figure out how to develop a unifying theory around how to do dashboards. So we're proposing, as we speak, a 2-year project that will start in this January, and run through December 2026. And it is an extension of a current project currently funded by the Robert Wood Johnson Foundation. And I have been asked to join it. So this is a project that already existed around data dashboards, and I was asked to come along as it expanded into looking more closely and intentionally at health equity. And as I've mentioned, the project is to design a framework or create a framework for designing, implementing, and the continuing improvement of data dashboards. This is our team. So in the middle is Itzhak Gavinsky, who's a professor in the communications department at my school, the Rutgers School of Communication and Information. And then Gretchen, she's at Florida State University. She and Itzhak have been working together on this, and they asked me to come aboard to basically represent the health equity piece. And we've been in fairly active conversations with the Robert Wood Johnson Foundation on exactly how we want to roll this thing out in January. So it's not official, however, it's right on the horizon. Now, the last project I'll talk about is a book, my first book project. It's only a project at this point because it hasn't been completely written yet, but it's something that has been on my mind for a couple of years now, and I'll get into that in a second. So the book project is called Advancing Health Equity, Perceptions of Racial Discrimination and Health Outcomes for Black Americans. The pandemic affected a lot of us in different ways. And one of the ways it affected me as a Black American and as a racial equity researcher is looking at what we call social determinants of health, which are very common things like poverty, environment, influencing health outcomes. Social determinants. Where you live impacts your longevity, your mortality. So, well-researched, well-described. However, and I used to teach that to students, but during the pandemic, something happened with me personally. I was like, these determinants don't just happen. It's not like, I use this comparison. It's not like gravity. Gravity, just natural law, happens. Well, social determinants aren't natural laws, right? When we look at, in the United States, certain communities that are characterized by poor environmental health, whether it be water, air, other factors, lead in the paint, those didn't just happen. Those were a result of individuals making decisions about certain communities and people that lived with them. These were industrial plants that were placed near underserved communities, or underserved communities that were developed near industrial plants. So this was something that was on my consciousness, but I hadn't really thought about until the pandemic. I thought, well, wait a minute. These things don't just happen where certain communities of color are characterized by these environmental factors, that these were decisions made by individuals to say, we're going to put a community here, or we're going to put a chemical plant here. So this notion, at least for me, that social determinants don't just occur like the sun rising in the east and setting in the west, that they're the result of decisions that people have made over years in many cases. And perceived discrimination is a social determinant of health. So if I perceive that a provider, an individual provider, or a healthcare system is going to treat me differently based on how I look, then that is a social determinant. But I wanted to get a little deeper into it. I asked myself, why do they persist? And what are the implications? And I kept coming back and continue to come back to the racial hierarchy. Not my term. It's a term that's in the literature. The racial hierarchy, as many of you may know in this room, was used to justify enslaving people of African descent. The racial hierarchy, simply put, is that there are certain races that sit atop, or race that sits atop of a hierarchy, and that there are other races that are beneath it. And at this point, I was, 8, 9 years out of my 2001. I started my PhD in 2011. So this is around 2020, 2021. So 8, 9, 10 years after I started my PhD, I started to think more deeply about the racial hierarchy. And I asked myself a simple question. If the racial hierarchy was used to justify enslaving people of African descent, and here I am researching health inequities, racial health inequities, what stopped it? I still haven't found, did it just go away? The racial hierarchy. I mean, it had this huge global influence. But we don't talk about that much in at least health equity. I didn't. And that bothered me. I said, okay, if we can acknowledge empirically that there was a racial hierarchy that justified the enslaving people of African descent. Of course, there have been slaves for thousands of years, but this was something new. What makes me think that it's done with? That the racial hierarchy, what happened to it? Did it vanish? Did we stop doing it? Did it go away? And what I continued to find as I looked a little bit closer at social determinants is that I saw no evidence that it's gone away at all. It may have receded in its influence a bit, or it may not emerge in the same way. But I call this the elephant in the room. And these are rooms I've been in, where I would talk about health disparities. And I would talk about social determinants of health. But what I wouldn't talk about is the racial hierarchy. I view that as the elephant in the room. The elephant's there, we know it's there, but we don't talk about it. Well, I decided that I wanted to write a book that would better explain the effect of the racial hierarchy. Racism is a cause of health inequity. So that's in the public health literature. And as I looked closer at some of that literature, I found this paper with this quote that I'll read. The racial hierarchy has long been an organizing principle of this country. This is the United States. So it is unrealistic that a program lasting a few years will have much impact on structural racism, say a diabetes diet program. Any attempt to dismantle and repair racism must therefore be long-term and have ongoing funding sources and/or have a clear path to sustainability. And around that time, I took a closer look at Kendi's Stamp from the Beginning. a wonderful historical text of race in a global context. And I saw some concepts that I thought I needed to incorporate more into my own work. Back to natural language processing for a minute. As I was poking around, that's what we scientists do. We're curious people, understanding the world around us. I saw that there was empirical research that I didn't do that pointed out that the racial hierarchy is embedded in the English language itself. This graph represents two dimensions. Americanness, so what makes something or someone more American, which as our political season starts to approach our election on November 5th, becomes even more a salient concept for me. And this axis is superiority in the language. So previously I talked about the Nursing Notes Project, where there were certain words that connote blame, blaming language, stigmatizing language. So too are there words in the English language that connote Americanness and that connote superiority. And in large-scale data sets, we found, I haven't done this work, that superiority sits according to a hierarchy. White people here, Asian, Black, and Hispanic are sort of equal in that regard, in that hierarchy. And then, just for the sake of completeness, Americanness, white, more American. Black, lesser than, but still American. Then Asian, then Hispanic. So, racial hierarchy is embedded in our very language. It's not just policy, redlining, for example, in the United States, where certain communities were placed and kept near chemical plants. So, there's clear evidence, beyond just the health disparities, that the racial hierarchy persists. Still here. It's in our language. But what's its effect on health and wellness? So, if we know that the racial hierarchy still persists, at least in the language, then what's the effect? What's the point? So what? Well, I decided that I wanted to explore how perceptions of racism, again, a social determinant, affects health behaviors and decision making. And my premise is that the racism is rooted in the racial hierarchy. That's kind of the definition. So if I'm perceiving that I'm treated differently because of my race, that's a result of the racial hierarchy and its influence persisting. But I'm interested in determining how that affects behavior. So if I think that a provider is going to treat me differently because of my race, and I might not take the medication that they recommend or the vaccine they recommend, that's the kind of thing that I'm interested in, because we have a large corpus of literature that describes how minority individuals, racial minorities, experience higher levels of mistrust in medical contexts. We also have a larger corpus of literature that describes how racial minority populations have different health behaviors. They don't go to the doctor as much. They don't have as many preventative screens. But there isn't much of a connection between those two phenomena, and that's what I'm interested in exploring. So, what I did is I decided to look at two groups of Black Americans. I won't say how I got there. It's not important for our purposes, and we don't have the time. But prostate cancer patients, again, Black Americans, prostate cancer patients, and patients who have had a diagnosis within the last 5 years, and people who have had a baby within the last 5 years. I took those two different groups and I thought, let me go deep with them. Why? Well, prostate cancer means something's wrong with you. We got to try to fix it. Having a baby, though, is something we celebrate. There's nothing wrong with you. You're having a baby. So there's one difference. Another difference, gender. Another difference, age. Prostate cancer patients tend to be older than people who are having babies. So I thought, might that be interesting? And what I've done so far is interviewed, one-on-one interviews, all virtual, from mid-July or so to September. Actually, most of them were done in August. 9 prostate cancer patients, 18 new mothers. And what I found, again, these are preliminary findings, is that the influence of the racial hierarchy is highly circumstantial. The prostate cancer patients talking to me about perceptions of racial discrimination as they access care, very different than what the new mothers told me. So, the prostate cancer patients, these men reported racial discrimination outside of healthcare settings. One participant in particular, when I asked, have you experienced racial discrimination? Talk to me about it. One of them said, I'm a black man from Texas. I've experienced racial discrimination my whole life. However, they did not report maltreatment as a result. But the women did. They reported considerable racial discrimination as they accessed care. They're younger. Their care is more episodic, urgent, whereas prostate cancer patients tended to have some time to digest and access what they needed. So the next step is to do online surveys to delve deeper into some of the phenomena I found in the interviews with white, black, and Hispanic people. Now, we're wrapping up. Health communication insights that I use. I wanted to share with you a couple of really texts that I go back to, papers I go back to, that communication inequities track with racial health inequities. Those are tied together. That communication inequities also limit racial minority access to care, and that community engagement is vital to crafting, developing health campaigns. Now, in summary, I think we researchers all, can do a better job of engaging further with the groups that we report findings about to tell better stories. And that requires multiple disciplines, like informatics, where I am, communication, journalism, media, public health, etc. And Brene Brown is a social work researcher in the United States who's fairly well known. And she has an expression that we should tell better stories, that maybe stories are just data with a soul. And as we found, especially during the pandemic, stories are greater than facts. We can hit people with facts all day, but stories is what pulls us in. And we should consider that as we design and implement large-scale campaigns. Finally, we need community. We need to be with each other to deal with some of these pressing issues and to support one another. And I use this in one of my talks actually in South Carolina earlier this year. And this community, I am because we are, this concept is so powerful and one that I need to revisit and continually revisit, that engagement is the key to this, to replenishment, to maintaining the energy, and to get insights. With that, I want to finish by thanking you for hosting me. That's us on Lamech and Lucio and me. Us last week at the Fairmont when we first came together here physically, and then, of course, having a wonderful day on Saturday viewing some of what Kenya has to offer. So with that, thank you for your attention, and I'll welcome questions.
So I have few questions. The first one is with the social media audience. So like getting information, evidence only from the social media community. You know, there are people on social media which holds their opinion sometimes. They look what is happening on social media. Is it like okay only to rely on the social media, like having a mix of the audiences where we got or the target audiences? So how do you see that, or doesn't that affect some of the validity of the information? I don't know what standard public health message means in the US, but conventionally in health communication, like pre-testing messaging is always a must and one of the principles. So how do you see, what does it mean standard messaging mean in the US? I don't know what does it mean in that area. So, and stigmatizing language, how do you see it with neologism? I mean, neologism is always there, like some words might be offensive in some time, and maybe after decades or some years, it changes, like, because society is a dynamic issue, so it's changed. And do you think it should be something static, or we have to study every time and modify and be adaptive about the language that we are using? And with the Russia issue, the last one, what should we do? I mean, such social determinants are common everywhere globally, may not be only typical to the US. If you go to Africa, we have also our own stratas, social classes. Some community members might be outcasted, isolated. So what shall we do? What should be the solution that we have to do? Even maybe in your book, that might be one of the interesting areas. What should we do about it? So thank you so much, and it was a fantastic presentation. Thank you.
Thank you. There's always a question where it's like, ooh, all right. I'll try to take them in order and tell me if I miss any of them. So the first one, is it okay to, social media represents only a subset of society. And yes, the short answer is no. We don't want to just rely on social media for public health messaging. But what we're trying to do is figure out how to become more efficient at determining what messages may work, and using social media as a tool, but not the tool, to try to develop messages and then propagate messages that are more effective is something that we use that for. Because frankly, I don't know of another way to get 10,000 people to chime in on what HPV vaccine would be more effective for them. So it has its limitations, and one of my colleagues actually exclusively works with social media data. And I tell him, I'm in the terrestrial world and you're in the online world, and which one is more reflective of who we are? And I joke with him about that, because the online world is its own community, and yes, there are some limitations to just using that work, doing that work. Now, as far as confirming like what messages should go out, certainly they should be tested like we test other campaigns, but our hope is that this method, which is fairly efficient, it doesn't cost a lot compared to other social media, other public health campaigns, and it can be adjusted fairly quickly. I think that's the relevant part of the method. Now, what do we do about it? What do we do about the hierarchy? And yeah, I think there's an expression, I guess Baldwin, I think this is Baldwin's, yes, that not everything that is faced can be changed, but nothing can be changed until it's faced. When I say the elephant in the room, I think that if we are more explicit at calling out the existence and persistence of the racial hierarchy, that will get us a little bit closer to actually developing techniques to root out its influence, where it's having influence, as well as what to do about it. Because I think that when we talk about social determinants and poverty and environmental health, I think that, and these are my words now, I think that sterilizes it a little bit. It sanitizes it in ways that isn't helpful. So if we are more direct, if we confront what it is, if part of it is a racial hierarchy, the persistence of it and its influence, I think the odds of us actually moving the needle on some of these persistent disparities increase. And yes, I would love to take this work beyond just the United States, and I would welcome opportunities to collaborate and extend what we're learning and then learn more in different societies, different cultures where the hierarchy may look a little different and where it may exert influence differently. Were those the four? Okay, thank you.
Yeah, thank you so much for your nice presentations. And I was keen on your study on public health messaging, where you tested basically the effectiveness of crowdsourced messages versus messages being provided by the public health authorities. And I was just wondering how, and it was a randomized control trial, maybe you don't have much time to tell us the details about the design, but I was wondering how you managed, how did you ensure that, because the public health messages basically go to everyone, so how did you ensure that there was no contamination, because everybody will receive the public health messages anyway? So I was just wondering how you managed that.
Yeah,
So let me ask the second question. It's about the dashboard. Yeah, the dashboard.
yes.
So I realize it's a 2-year project.
Yes.
So how do you plan to, is it just after the 2-year project is, what will happen? Will there be sustainability? How will it continue?
Let me be brief. All right, so contamination with the, so in theory, everyone can receive public health messaging. What we're doing, though, is comparing the messages that the community came up with the public health campaigns. So our participants are getting both. So I think that helps root out some of that contamination. Oh, and the dashboard. The dashboard is about a theory development. So what we're going to do is try to coalesce a unifying theory on what makes public dashboards effective and usable. So in 2 years, I think we can get to a sort of theoretical model for public health dashboards.
Thank you so much for that lecture. It was really good. Thank you so much for showing us the different projects that you're working in. I was really particularly impressed by how you're using community engagement and public engagement to inform kind of decisions in the healthcare system. So I have one question. And it's about the racial hierarchy and your approach, your projects. You seem to focus on the Black, and you said you're focusing on the Black or African American and those who are in the Republicans. So my question is, why only those? Especially why only the African American? While you see when you talk about the hierarchy, you show that, for example, the Blacks are more considered more American than the Asian than the Hispanic, and the Black and the Hispanic are equal in terms of superiority. So I wondered why those were not, and I also don't know where the Latinos are. So why only the African American and not the wider scope?
Okay, let me try to clarify that. I apologize if that was not clear. So the public health messaging is a different project. We didn't necessarily hone in on the racial hierarchy for this. What we were doing, though, is these communities of interest for the HPV and COVID vaccination perceptions. We were interested and are interested in targeting communities that experience disparate perceptions and therefore disparate access to the intervention, the vaccine. So this, we're sampling based on the community-derived messaging is about going to communities that experience disproportionately less vaccination. So that's why we picked Black African Americans and Republican voters for the U.S. So that's one project. Now, the racial hierarchy in the language, let's go back here, is, oh wait. hold on. The racial hierarchy in the language study, yeah, here we go. Okay, this is looking at the English language and what makes language that sort of suggests who's more American and superiority. And this is just about what the U.S. English says about superiority, the hierarchy here, Black and Hispanic here, somewhat equal, white, Asian, Black, and Hispanic. And then what's more American? White, Black, Asian, and Hispanic. So they're different. So the hierarchy is here, sort of on display in our language, and that's important to consider as we're training language models to make decisions or to help inform decisions. But that's separate from what we did in terms of targeting the public health messages.
Sorry, just to confirm, so the mistrust in the healthcare system is mainly only amongst the Blacks, the African Americans, and not among the Latinos and the rest of the non-Caucasians.
Yes, so in the U.S. context, when you look at groups that are most likely to support medical mistrust, and there's actually a medical mistrust scale, a scale that measures that specifically, you see across groups, across studies, that Black Americans report higher mistrust than other groups do. Okay?
Okay, I guess I'll go next. I was quite taken by your presentation regarding the work we did with the Latinx community in New Jersey. And then through your focus group discussions, you discovered that what they needed really was an app that had clear information and it was easy to use. And it got me thinking about the Mpox situation that's going on right now. And of course that calls for policies, governments making decisions, and also behavior change communications coming in strongly. And if you look at a continent like Africa, roughly 50% of Africans can access Facebook. But then there are parts of Africa like Central Africa that are largely forgotten. And they're behind in terms of internet penetration, mobile penetration, social media penetration, all of those. And it sounded like you either have used or have used elements of participatory action research quite a lot in your work. I just wanted to find out, have you used participatory methods in your work? And also things like web scraping. And have you found them useful? Do you think this could work in helping increase awareness about Mpox, particularly in under-resourced areas like Africa?
So yes, so this is a community-based participatory action research project. This is me partnering with Teresa and going to the community to figure out what the needs are. And yes, this is an approach to research that's near and dear to me, and I do that quite a bit and try to do it even more. But as most of us who have done this work know, it's time consuming. It's hard to, there's a lot of uncertainty to it. When you go to communities and ask and seek their input on how to design a project, a research project, then the study design may look very different than the one that you were thinking of when you came in. That's part of the point. So yes, yes, and yes. Community-based participatory action research is a approach that I tend to use. I enjoy it. And I enjoy the results that I get as a result of having done it. Web scraping, again, that's not work that I do. So I'm not, for example, scraping Reddit forums for perceptions of vaccines. But there are people actually in my department, colleagues, who do that kind of work, but that's not work that I have been involved with. Can participatory action research help us understand the dynamics in areas that have very low internet penetration? Yes, I would argue that I don't know how else you could get insights there. So when you mention Central Africa, areas that don't have high penetration of social media or internet access, I would say participatory action research would be the way to try to tease out some of the phenomenon, some of the perceptions, and some of the ways to approach them in a way that's going to result in better research.
Thank you, Charles, for sharing your experiences. My first question was around the first presentation that you made on the project. I just wondered, I know that it was an online experiment and there were messages that were coming from the communities. But how confident are you that those messages were from those communities? I could have been in the US or I could have been in Africa also, tying into those messages. And then the second one was mainly around the non-stigmatizing language, or the use of stigmatizing language by healthcare providers. And it made me think more about trying to situate it here in Africa, in our healthcare field, the use of the language that healthcare providers use. I mean, it was new to me to see that using non-compliant or poorly controlled can be stigmatizing. And I wonder, is this something that is, are healthcare professionals trained to use non-stigmatizing words? And then I was just thinking, to try and situate it in Africa, we may not necessarily have racial issues, but I should to say that it does exist, that hierarchy. But for us, it would probably be more socioeconomic hierarchy, unless that word even exists. But trying to think, how do you go around that within our context? I don't see racial being much of an issue, but it could be, or maybe we haven't thought about it. But I was trying to situate it in the clinicians here and whether they have that mindset that, you know, when you're writing these words, you're likely not to offer this person treatment sooner than someone who is not. I mean, if you had used better words, that's what I wanted to pick your brain on.
Sure, thanks for the questions. So let's take the online experiment first. How did we know that the people who were responding were from certain areas? Well, as you may know, Facebook has a way of targeting certain users with ads. That's part of their model, and that's part of what they don't necessarily share how they do that. But they have a fairly robust way based on people who approach certain Facebook pages. We took Facebook pages as our platform from these areas, who serve them, who provide information on vaccinations, say in Mexico, who provide information on vaccinations in Brazil. And we purposely used their platforms, in conjunction with them, of course, to run these experiments. So, yes, I mean, all studies have limitations. However, for this one, we can be reasonably assured that if a Facebook user is seeing an ad that's posted on a vaccination in Brazil's Facebook page, that they're probably coming from there and not from some other region. That's our assumption. Now, in terms of stigmatizing language, are providers trained to not use this language? The ones that I train are, yes. So this is not, I'm not going to say that this is a very well-known phenomenon. It's well-researched, but in terms of providers knowing that when they use the word non-compliant, that is stigmatizing, I don't think enough providers know. I'm a community health worker instructor. I'm certified in the state of Texas as a community health worker instructor. And I would tell my community health workers that I was working with in training not to use compliant. I call it a C word. It's a bad word in this context because it's blaming, and it connotes a level of control that the provider does not have, complying with the wishes. Anybody that's treated patients knows that you make suggestions, but the patient ultimately makes decisions about what they're going to put in their body or not. And how does the hierarchy translate here? I'm not sure. I think the larger point is to understand if there's a hierarchy in place, whether it be by religion or other dimensions. And if it is, what effect might that have in how people are treated? Are they getting disparate care based on that hierarchy?
For me, I think it's a comment rather than a question. And one time I came across a word called epistemic injustice in global health equity. And one of the things that we were being taught during that training was how a lot of the things that we have come to know as Africans have actually originated from the center. What do I mean by center? Center is where, the colonialists came from. So a lot of the English words we use are actually originated from them. And so even as Shukuru is talking about stigmatization, these languages we are taught are not ours. And so we can't actually know how to differentiate it. And then there's also the part of, as I mentioned, center. The center could be the colonialists, or it could be us as the researchers. And the periphery are the people we work with, the communities we work with. And when you engaging them in community communication, it's actually important because then you're giving the periphery power and making them the center. And we become the periphery, learning from them. And so I do really appreciate what you're doing, and I think it's the way to go, even for all researchers and anyone in global health space. Thank you.
Thanks for that. Yeah, not all health equity research has to be community engaged. There are some people that say that, but I'm kind of leaning that way. I don't know how you do this work effectively without engaging with the populations that you're trying to learn more about and support. So thank you for that support in that area. Yeah, it's...
Thank you for your presentation. Just two quick ones, or three. Why Facebook in the first place? And then the message dissemination. Were there specific considerations around the time that those messages were going out as you were disseminating them? And then were there issues around the language, whether the formality or informality of them? And then in the crowdsourcing, were the demographics a factor? For example, the ages of the people that were actually giving those messages, the gender, and so on and so forth.
So why Facebook? Well, initially we were thinking about Twitter or X and Facebook, but it just so happened that we were able to partner with Facebook to get credits for the ads that they normally charge for, right? That's a big part of their revenue model. So we picked Facebook because our agreement with them enabled us to run these ads over and over without it being exorbitant in terms of the cost. As far as the appropriateness of the messages, they were vetted. So when the community decided to, this is one of the questions that we had pretty early, is that what if a community that that believes that HPV vaccines are harmful, what if they come up with ads that say that? So the ads were vetted by our team. Once the community said these are the top 10 ads, we would look at them to make sure that they weren't putting out harmful information, and they weren't, generally. So they were generally reliable in terms of their messaging and appropriate. As far as the demographics go, we don't have any idea who these people were. So we don't know. Like, Facebook doesn't share their user information with us or anybody, as far as I know. So we don't know the age, the gender of the folks in the experiments. They're completely blind to us.
What of the formality?
Of language?
Yes.
Again, that's the community determining what messages would be appropriate for them. So we didn't really have a point of view on how formal or informal it should be. That was part of the point, is to have them tell us.
My question is around the impact of the implementation of the various social behavior change campaigns, especially on social media. How are we able to justify the impact of these campaigns right at the facility level, not only at the community level? Let's say we are creating awareness of the treatment adherence around something like tuberculosis. Are we able to measure the impact at the facility level? More people adhering to treatment? And what are some of the tools or reporting tools that someone is able to use for this?
Yeah, it would have been nice if we could actually not just measure intent, but also follow up to see if these people actually, say, got a vaccine. But that was just beyond the scope of what we could do. Ultimately, though, those of us who are interested in outcomes are interested in behavior, right? That's the point of even the book project, is to try to create pathways from perceptions to behavior to outcomes. That's the whole point. That's really what drove at least my interest in this topic. However, there's certainly follow-ups that you could do with people, right? You could measure attitudes about vaccination. You could actually be, just using vaccines as a proxy, you could ask people at the facility to say, okay, what brought you in? What campaign did you see a campaign? Is that why you're here? So you could ask people, why are you here to access this care? What brought you in? Was it a friend that told you? Did you see an ad? Was it on the radio? And that would be a way to determine how, to draw a line from a campaign to an actual behavior. Is at the facility, you could ask people.
Thank you. In a situation where health messaging could be impacted by, say, religious beliefs, we've had that situation in Kenya when the Catholic Church negatively impacted a major government initiative where it was assumed that the real reason behind the vaccination was to sterilize, particularly women of childbearing age, or where we have senior government officials come up with all manner of conspiracy theories, and that did impact COVID vaccination. How do we then model our message in a way that we can move beyond some of these very significant obstacles that would impact major populations? We have a community in Kenya that doesn't believe in vaccinations, and we have seen facts break out when, say, for example, polio vaccinations are taken away. So how do we model our message to ensure that such communities are not left out in our messaging, and they can then participate in accepting vaccinations, which we know are life-saving? Thank you.
It's a tough issue. I think that, back to the question previously, if you engage with people, they might not believe in vaccinations, but they believe in something. So my approach, my and others, is to, if you have a group that you need to try to reach with a public health campaign, and I'm not necessarily a designer of campaigns. I mean, you've heard a little bit about some of my work, but I've learned in doing this work that even people who might study or come from specific groups still have a lot to learn about those said groups. And if there's a religious group or another group that doesn't believe in HPV vaccinations yet, then, and I use the word yet purposely, then they believe in something. Get close enough to figure out what the other beliefs are and have some dialogue about what it is that you're trying to bring and what they can bring to you. I think the notion of reciprocity is really important as us researchers, the ones with all the fancy letters and fancy credentials and fancy methodologies. At the end of the day, we still have a lot to learn. And where do we learn that? Well, we learn it from the communities that we are attempting to serve. So what I try to do is, even myself, is to stay close to the communities that I am thinking I'm trying to support, to learn more about how they might be experiencing an issue, they might be experiencing campaigns. And also, I want to point this out too. I was given a lecture a few years ago to public health students, and they were asking me about how you can affect change in some of these very distressed communities. This happened to be in Texas. And it occurred to me that there was a distance in the tone of the question, like, how do I help those people? They didn't use that term, but those people. And I just kind of came up with this as I was interacting with these students. And I would say, and I've said it since, is find yourself in your patients. Find yourself in your participants. We have far more characteristics that tie us together than separate us. So if I'm advising a group that's trying to reach a religious group that is anti fill in whichever vax, then I have to also consider when I was anti-vax or when I didn't understand or believe in something until I did. So finding yourself in your patients and finding yourself in your participants means to recall times when you weren't as enlightened, when you weren't as woke, when you weren't as educated on some of these issues, and how was it for you? And I like to say that we all don't evolve at the same pace. And if these folks don't agree or are anti-vax, use the word yet. They're not there yet, because there was a time when I wasn't there for certain issues. So engaging with communities not only provides you the kind of reciprocal relationship that's necessary to affect real change in these communities, but it also enables us to remember when we weren't as knowledgeable and we weren't always following recommendations when it comes to our own health behavior.
A lot that we are learning now that should be unlearned, that we find it's not just on racial, but also being used on vulnerable groups or the key populations, the drug users, and everyone else. For example, I think the word sexual is so much negative. Like when you come to the ground, you find it's different. So I keep on wondering, are we going to change all the English languages and adopt the local language, which is not in English itself, and put them into the dictionary as well, so that we don't see the Englishness in these languages or terminologies, and we see more acceptable or everything? Because if I thought sex work was universally accepted, when I come to the ground, it's like I'm abusing people. And we are wondering what to do. Prostitution was already changed, which was there before. Now you have to check for language. And why I say that is fluid, when I go to the community of sex workers, are more acceptable if I talked about us being sex workers than they're being prostitutes than using sex work. So you find us people who are anthropologists, and we are working along this, and languages, you keep on changing and it's fluid. So when we are doing your work, I would want to hear more about that. Thank you.
Thank you for the question. I think that was Emmy. And I'm going to try to decipher that. I think I heard that, but if somebody heard differently, let me know. I think the spirit of Emmy's question was in doing work with sex workers, stigmatized groups, that it's important to approach them understanding that not just your language, but your tone and orientation might impede some of the data you're trying to collect, insights you're trying to collect, interventions you're trying to design, etc. And I'm glad you brought that up, Emmy, that it is important to understand what local concerns and customs and norms are, whatever local may mean, because I actually had a colleague, a mentee, that did outreach work with sex workers in Senegal. And I was working with him in the summer of 2017, Douda, in Senegal. I wasn't there that time, but he had to educate me on how sex workers had a different sort of, it was different in Senegal, at least that part of it, than what I would consider sex workers were in the US, prostitutes, if you will, and that sex workers were regulated, that there were certifications for them, and that they accessed care in their own way. And I just had to understand a bit more about the context, the local context in which our work was happening. So I think that that's a lesson perhaps for any of us that are doing outreach, public health type work, is that local norms, local contexts are really important, and it's important not to make assumptions about them as we endeavor to try to make change in those communities.
I think this presentation is really important. Most importantly, Charles, as you might know, we have a very big policy engagement and communications unit here at FHRC. Maybe you can understand exactly why you were receiving lots of questions. And as an organization and as people who are very interested in policy, it's really important for us to be intentional when it comes to the language that we actually use. I think one of the best books that I've read is actually a book entitled The Anthropology of Language. And recently, as I mentioned to you, we have a visiting scholar, Daniel Krugman, who is working on decolonization of global health, and his focus is actually on how language affects perception and interpretation of decolonization of global health. In our strategic plan for 2022-2026, we are very keen on partnerships. And we think that, as I mentioned to you, we are really going to be very key in seeing how your Institute Communications Unit at Rutgers and the broad Rutgers School of Public Health we can actually collaborate. As you see from the questions, you can actually see that there are actually a lot of areas where we can actually collaborate. So I want to thank you again immensely, Charles, for coming, and on behalf of APHRC, I would just like us to stand up and give what they call a 5 analog clap for Charles. So when I say 5, you clap 5 times, 4, you clap 4 times, 3, you clap 3 times, 2, you clap twice and once. So 5, 4, 3, 2, 1. Thanks so much, Charles, and unless I forget, I want to really thank Juliet from the head of Visibility Unit, who has been very instrumental in making this happen, and this wouldn't have been possible if LAMEC really did not put in the package to make it happen. So thank you very much, LAMEC. Thanks so much, colleagues. I think the discussion can continue over coffee. Thank you.
Thank you.